Hello, I want to talk about the January and February training that we did and sort of summarize a few key points. So we're going to be talking about documentation a lot more this year, so I'll touch on that briefly. But to go back to January, we talked about pulse and DNR orders. When we show up on scene, obviously our default should be to start CPR. If you don't do that, you should have a good reason why not. But again, that should be our go-to. You can always stop if somebody produces paperwork sort of into the resuscitation. If there's any question about starting or stopping, or again, we should be starting. If there's a question about stopping, once you have paperwork, if you can always use your partners, talk to the captain. You have lots of people on scene typically with cardiac arrest, so make your best judgment in your own mind, and also use the people around you to help make your best judgment about like, no, this we can stop. It's pretty clear the family wants us to stop, whatever that case may be. Again, we need documentation, but there may be times that you can use your best judgment as well. If there's ever a question, you can call. Most of you probably have my number. If not, call online medical control to discuss it. But you have some options there. A side note, something that I thought of, if any of you are interested in pulsed and DNR things in particular, there's probably room on the back end, not on calls when we actually go code 3 to these things, but on the back end. If you want some sort of fire department community initiative to try to get more people in our community to have pulsed and DNR orders, which would probably pay dividends down the road if that's near and dear to anyone. Talk with your captains or talk with me or the chiefs, and we could probably figure out some way to try to do that as a department, and somebody could take on that project to try to get more of that in our community, which would probably help us again down the road. So as far as cardiac arrest goes, we're not making any big changes right now. We're still using yellow guard. We're using this double sequential external defibrillation. ECMO is still around for things like hypothermia or drowning, but our go-to are going to be really capitalizing on BLS skills, doing good cardiac arrest care, getting to the patient quickly, using the yellow guard, double sequential defibrillation, doing all our basics really, really well. So really no big changes there to talk about. So in February, we talk more about documentation things. A couple things to keep in mind. The SOAP note is pretty familiar to everybody, the subjective, objective assessment and plan. In your narrative, you need to have some chronological story of what happened. And again, I think we need to talk more about this as we get into what documentation we have to have, what's beneficial for the patient, what helps us get paid. There's a game that we have to play in terms of what the insurers need to bill insurance or get insurance to pay. We don't want our patients stuck with a bill if we can help it. So we need to be accurate about what we're documenting, and hopefully that insurance then pays the bill for the patient. Otherwise, we're not doing we're doing our patients a disservice if we're not documenting accurately, right? The goal is not to make money in EMS. The Edina Fire Department's not making money, but we do actually need to pay the bills. So again, there's a system that we're in when it comes to the billing and the insurance that we have to be good at what our portion of that. So paying attention to the details matters in your narrative, and the way to get better at this is to get more reps. So read your partner's charts. I highly encourage that. You're signing off on your patient's chart, take the time to actually read them. Another thing that's useful is read them out loud to correct your own grammatical mistakes or things that just don't sound good. There's better ways to say things. So there's people that write great charts all the time. There's people that struggle with writing charts. So the more you see, the more you can see like, oh, that saying it that way was not very good. That was not very clear. But oh, this chart, when they said this was very descriptive, and it was very useful. Like saying something that way was very good. So be observant about what you see. And then this speaks to the non-formal parts of your physical exam. When I walk into the room in the ER, I'm reading the room right away and seeing what the patient's doing. If they tell me they're in severe pain, never had pain like this before, but they're on their phone playing Angry Birds and texting, and clearly they're not dying, if you can do that and you're sitting in a very relaxed position doing this, so it doesn't match. So pay attention to that stuff and document clearly. And it matters when you get to the ER too, like a physical exam finding like either a stroke or a head bleed. If you see the patient moving their arms, but then on formal testing, they can't follow commands, maybe they're just confused and that's why they're not lifting their arm, but you've seen them do this and move both arms on scene, that's useful information to the providers down the road. So some other things, don't use the third person. You can just say I. You don't have to say this writer, this medic. Just use your I, use first person. If you're signing a patient AMA, against medical advice, there should be some documentation in the chart that you tried to convince them to go. If you show up on scene and somebody else, let's say a third party called for a patient and they have no interest in going with EMS, and whatever the situation is, maybe it would look like a bad car accident, turns out it's not really that bad. They don't want any care. You don't think they actually need any care. You don't have to try to convince them to go if they really don't need to go. But if you show up on scene and somebody really is sick, or you are legitimately concerned that they should go and they don't want to, then you should document very clearly, we offered to take the patient, we recommended that the patient go, we talked to their family, we recommended that the patient go. So if it's an AMA, you should document that you were trying to convince the patient to go, that you really wanted them to go, and they are really not going against medical advice. You can't say they're AMA and then not document a conversation like that. That doesn't make any sense. So related to that, if you do less, an idea like in my job at the ER, if I do less, I need to write more. The 70-year-old guy with chest pain is going to get all of the usual things with you or when they come to the ER, right? That's a chest pain workup, right? You're going to check the box on all the big bad life threats and all the serious things. If I don't do that in the ER, I need to document why I don't think this guy needs that. Maybe it's his story, like his chest pain was really like, he had 1 second twinge of chest pain 2 days ago and that's it, and he's had no other symptoms. I need to document really well that I'm not working up his chest pain, right? So same thing when you're on scene with somebody. If you do less, you probably should err on writing more and justify why you're not doing something. So those two kind of go hand in hand. And keep these words in mind. This is key to better documentation. It's key to communication on the radio. It's key to in-person communication when you're on scene. Precise and concise. So say the things that are actually true. Say the things with the best language you can come up with. I don't have a perfect example off the top of my head, but you need to be very accurate in what you're saying. You don't speculate about something that you didn't actually see done. So just be very precise and concise as best you can. And this speaks back to getting more reps and doing more charts and trying to use the best language possible to convey exactly what happened. So your narrative really needs to convey the picture of what happened. And we talked about this in training. We talked about some of those calls by the patient who had fallen a couple of steps and then needed help getting back up. That one, again, if you remember, was pretty clear. All of us could kind of picture what happened. This lady walked out of the bar, she tripped on a couple steps, hit her face, she was assisted up. So being able to write that precisely and concisely so that sort of everybody who's reading that chart kind of has the same picture of what the injury was and how the patient was doing. Right? And this I'm stealing from a colleague of mine at EPA. Whatever you considered, completed, or communicated about the patient makes your chart that's covered and compensated, right? So again, consider to be your assessment and plan. Like the differential in your assessment is what you considered, what you completed, that's what you did for the patient, what you communicated to the patient, to the family, to your partners. So those things all go hand in hand, and then you're covered. And again, this is not, we don't chart things to do CYA. We don't chart things just for the fact that we're covered, like covering our own butts medical legally. But if you do all this well, then in retrospect, you will be covered. So either in a legal situation, if a call comes up, if there's a patient complaint, if it becomes a legal matter because of some bad outcome, if we do this well, then we are covered that way. And again, related to the insurance, we need to be compensated. We're not trying to make money, but the patient, we don't want them to have to pay money too if their insurance should be paying something. So again, whatever you consider, complete, or communicate, document all that, and then the chart should be covered and compensated, which is good for our patients. So have a good day.